We'll admit people.
Okay.
It seems we need a little bit of time, some 2 minutes before we are officially, you know, on the on the stream. We might need a couple of minutes, but we can at least admit people, not to keep them waiting. Okay. We're online, Sue, so I think we can start.
Okay.
Well, hello, everyone. Hello, everyone, and welcome to another session with Rights and Responsibilities Awareness Initiative. Today, we have Sue Miller from London Health Science Centre to talk about a very, very important topic. So welcome, Sue, and
Thank you.
The floor.
Are we all set? Okay, so my name is Sue Miller and I work at London Health Sciences Centre. I work very closely with the palliative care department and a lot of the other departments when people sort of get closer to their end of life. So that's what we sort of wanted to share with the community is that things may be different here than where people have come from. There may be opportunities for care that they didn't think of before. And there may be things that they would like to access or things that they just may want more information about. So that's basically what we're hoping to achieve here. So in Ontario, can we go back to number 2? So in Ontario, palliative care and its goals, palliative care is available in what locations and how would you access it? And what are the choices that are available as well? There's many different levels and locations and choices that you can make, but they are all sort of up to you and all regarding the same thing, how you envision what happens for either you or your loved ones at the end of either your life or their life. And how can we help you get there? But it's ultimately always up to patients and families what they would like to have happen. Okay, can I advance it? Nope, I don't think I can, darn. Thank you. So just briefly in Canada, this has been something that's sort of been a bit late in coming in my mind, because I think we all know people have been dying since the dawn of mankind. Whoops, can we go back to the last one? Sorry. So just to let people know that back as far as 1974, that was when palliative care units were created in Canada. Other than that, it was simply something that happened in the hospital. And this came on the edge of the research from Elizabeth Kubler-Ross with, you know, how people grieve, how they get to the end of their life, how they look at their own mortality. The goal was to provide an academic medical field in which to study, improve the treatment options, and an understanding of end-of-life issues for everyone involved, the family, the patients, friends, and the medical staff as well, because it can be a difficult topic to discuss. Okay, next slide. So around the world, some countries are a little more forward-thinking and allow things to happen a little more easily. In the United Kingdom, in the 80s, palliative care formally became a subspecialty, and you would take 2 to 3 more years of medical school or medical practice study as a fellow and resident. In the USA, it became a subspecialty not until 2006, which is very far behind. We were a little more in line with the UK. The World Health Organization defines palliative care as an approach improving the quality of life of persons and their families that are facing everything that is associated with a life-limiting illness. So what it is you've had a diagnosis that is basically saying you may have a whole lot of treatment, and it may be very high-powered treatment, but we cannot guarantee you that this isn't going to cut your life short by some number of years. Some people choose to have treatments, some people do not. You never have to have a treatment that you are not comfortable with in Canada. If you are diagnosed with cancer and you do not wish to go through chemotherapy or radiation, you absolutely don't have to. No one will ever force you into those things, but they will provide you with the best information to make decisions. The point of all this is to provide some prevention and relief of suffering by the means of early identification of diseases, early identification of what it is that people would like, just impeccably assessing their past, their family life, their spiritual life, what things they hold dear to themselves. Do they have things in the future that they're looking forward to? People will, they'll do chemotherapy if there's a wedding coming or if there's a child being born. And they have things that they want to get to in their life. And that's often what drives their desires for things. Next slide. I don't know if I can advance them or not. Patients and their families are supported through the whole thing, irregardless of what their illness is and possible treatments. So no matter what you're doing, you're going to have the support of hospital staff, home care staff, clinic staff in the community, relief of suffering via pain management and the management of the other symptoms that may come at end of life, such as nausea, anxiety, depression. These are all expected and all very normal. Those sorts of things, we all have medications and we're all trained for. So someone that does not work in the medical field may be very upset by someone who feels that they can't breathe and is panicking. I would have more experience at helping, even until we can get some medications for them. I have better experience at helping calm them down, do the breathing exercises with them. So it's just imparting that knowledge to families that there is someone here, and to patients that we are here for you, because we don't expect you to go through all of this alone. Improvements to the quality of life for everybody, for the patient and the family. We would like to help ease some of the care needs so the family can have some normalcy and rest, as well as spend quality time with people. We feel that although your initial reaction is, this is my mother and I will care for her, the reality of it as time goes on can be that you may have children, you may have grandchildren, you may have a job that you cannot take a certain amount of time off of. And knowing that you can have a backup plan there is often something that people really like. And it's often something that you may never think you're going to be the kind of person that would take advantage of that sort of stuff. But I can tell you, I did not. I cared for my parents until they ended up going to the hospital, and they spent about 2 to 3 weeks there, and that was it. I sort of didn't visualize myself as someone putting them in a hospice or a palliative care place or something like that. But I did get a little exhausted at the end of it, because they lose track of time. They lose track of, is it day or night? All of those sorts of things. And you need the help of the medical professionals, even if it's just a little help with medications and a nurse coming once a day to see them, or PSWs coming. It is important to seek out some help, just for your sense of comfort, as well as for the comfort of the patient. They'll get the professional person helping them out. And it means everything: spiritual, practical, day-to-day needs. Do you need someone to help drive you to an appointment? Anything: medical, psychological, social, emotional. Translating at the hospital, we have translators that we always try to have in a reasonably okay amount of time to have conversations, especially big conversations like this. Next slide. So palliative care can be different than what's called terminal care. And it can be hard to see. Palliative care is called life limiting. So it's something that has any kind of a prognosis that is going to shorten your life. Cancer can shorten your life if you don't have treatment. It can still shorten your life if you have treatment. They speak in terms of 5-year survival or 20-year survival. Neurological diseases, there are a number of neurological degenerative diseases where the person loses the ability to care for themselves. That can take a toll on the family, especially if they want to stay home as long as they possibly can. Caring for someone totally all day is exhausting. And so there can be some palliative treatments that are focusing on the quality of the remaining days and months. Palliative treatments such as surgery, radiation, or chemotherapy can all be offered. It doesn't mean that you're looking at curing your disease. They can be offered to diminish the size of a tumor, to take something out if it's surgery and make you more comfortable. And some of these things will actually lengthen your life. I've seen patients have another full year of life with their family if they have one procedure and they're in the hospital for 3 days and they go home. So there are things within palliative care that do extend your life as much as you would want that to happen. At some point, however, the patient would progress to a stage that's sort of known as end of life care. And then they would proceed to a more final stage, which is considered terminal care. And that is going to be the final sort of days before a person passes away. If you can go to the next slide. So end of life care really is the illness is non-curative, and often doctors will literally just say that to you, that there isn't really anything we can do for you. There may not be any medical or surgical options, or the person may wish to stop the treatments themselves. Some people just simply tell their doctors that. It's not unusual for some patients to feel that they're letting their doctor down by choosing to do that. And we do have conversations with people where we say it's about you and your life, you're not letting the doctor down. Some people may have months to live, and the primary goal at that point is to have good symptom control. How do we maximize the quality of life remaining for them and their family? If we want their grandkids to come and see them, if they have a pet, we want them to come. If they're in the hospital, we make arrangements for them to come and see them. All of those sort of things. And at this point, the person is aware that they're dying. It may not be immediately, but psychosocial support for the family and spiritual support for the family and the patient, paramount at this time, because this is where people are struggling with the fact that they will be dying and they will not be here with their family. And that's really hard for everybody to get, comfortable with. No one ever does. I tell people there will never be a time when you see both sides of a coin. You don't want your family member to suffer. You also don't want them to leave you. And it takes a long time to, we all know that we mourn the loss of family members for quite a long time. Next slide. So when we do become closer to the end, that's called terminal care. It's usually a reference for people who have days or even hours to live. Medical staff are extremely well trained at recognizing very subtle changes in breathing patterns and the level of consciousness and the amount of interaction with other people in a room. When I was nursing at the bedside, I would always tell people, what do you want me to phone you for if they went home for the night? If her breathing changes and I feel uncomfortable, do you want to come in and be with her? And most families feel that they do. And I would say, now, is that okay if I'm wrong? And they're fine. And most families are okay with that. If that goes on for a huge amount of time, families sometimes will rotate who is staying awake through the evening and night with patients if they want to make sure someone is with them all the time. But it's impossible to pinpoint directly. So I find it's best just to be open with people and say, I think I'm going to be able to see small changes. and I'll phone you if you want to come in, but I could be wrong. And if the patient is in pain, the relief of the pain is the most important goal at this point in treatment. That may make the person drowsy because of the medications that they're given, and that's always discussed with everyone so that they feel comfortable knowing that although they're sleeping through most of your visit with them, they know you're holding their hand. They know your voice. I firmly believe that anybody knows their family's voice as opposed to a stranger's voice. They may not know what you're saying, but it's very comforting for them to hold a hand and hear your voice. So family support here and spiritual care, very important if that's what patients require. We have a couple of really great spiritual care providers who act in all realms. They've got educated, they of course themselves will have their religion of choice, but they've done training in being spiritual care providers for anyone of any faith. And they're great. We can call them at any time. Next slide. So where does all this happen and how? You can literally be in the hospital having tests, and one of the tests was relayed to you at your doctor's office. Unfortunately, you may be told that you've got a serious life-changing illness or a terminal illness. You may be in the hospital having tests and you're told while you're in the hospital. We have some people who it's so serious that they elect to remain in the hospital until they pass away. Some people will go home. They may come back and forth to clinics and checkups, and they may have treatment. And then a year or two later, they may advance to something, or they may be cured. It's never say never sort of a thing. You will always be sent to a specialist in the field of your disease, and it's always up to you whether you wish to pursue something. So they'll give you what the best information they have is with regards to percentages of cure, side effects, what people have found with these treatments, and they're your best person to talk to about what do I have ahead of me. They'll be able to refer you to a palliative care specialist. Excuse me, should you decide that if you're quite elderly and you don't want to go through something that's going to be taxing and hard, you may decide that you just want to be palliative care and let nature take its course. And they're able to refer you to someone. Next slide. So where palliative care, there are at University Hospital and Victoria Hospital, there are palliative care units. And these are mostly for the people that are in, they've come in and they're in a crisis. They've got tremendous amounts of pain, or they have been at home and they have decided this is all too much. And I need to be in the hospital where there's someone to help me out. Or they've been on another unit and they've decided that they would just rather have palliative care and they get transferred to that unit. There is a palliative care unit across the street at Parkwood Hospital as well. It's a very nice, big, modern palliative care unit, and you can stay. The hospitals are a little more acute care. The palliative care unit at Parkwood has quite a bit longer stay. And then there is also hospice, which is an entire structure. There is a hospice in London, in the North End on Windermere. So the entire structure is devoted to people in the last days of dying or in the last weeks or months. Families are encouraged to do as much as they can, staying over. They've got spare rooms. It's actually a really beautiful building. You can bring in your own food that they would like, do your own cooking for them. There are things that they have for patients that are feeling a little better and maybe the family can't come in that day. They will know what the person likes to do, and if they want to be read to, that's what they get somebody to do. If they want to do some crafts or knitting, then that's what they help them with for that day that their family can't be there. At this point, you're not receiving active treatment. You're going to be seen wherever you are. If you're in the hospital, the palliative care doctors will see you. If you're in one of the palliative care units in the other locations or the hospice, they will see you there. If you are at home, we have a thing that's called PCOT, and it stands for Palliative Care Outreach Team. These people, it includes a doctor to manage medications, a nurse to come and visit. I'm not entirely sure how often. It depends on your situation and how many medications. PSWs to help with care, and a structure of medical care that is going to help prevent symptoms from getting out of control. People can move between those worlds. We have people come from home when their pain is out of control to the hospital. We get things under control a little better, and they say, I just want to go back home and look out my bedroom window at the fields of flowers, and away they go back home. So we want them to be where they are. We want them to be where they want to be, and we will go to wherever they are. Okay. Next slide. So having said that, many people do want to stay at home with their family, which I think is absolutely the most natural thing. It's a lot to take in. You're in your final moments of life. You may all be elderly and already live with a spouse and or children. So as I said, the PCOT team includes all of these medical care providers. If the person is at home already and receiving some level of home care, the care coordinator is the person to ask about palliative care. So if you have a family member who is just quite elderly or has had a stroke or one of those sorts of things, and they're going, we would say that phrase downhill, but you feel they're getting sicker, they can provide an assessment at home with a palliative care physician, and they can come and visit you at home. So there's not even any need to really go to the doctor if you've got already home care coming in to help with PSWs and some care of the person at home. Next slide. So for people, it's extremely difficult to decide what you want to do. Some circumstances, people want to have to be in the hospital. I find when people have breathing difficulties, they enjoy the security of pushing a button and a nurse comes to the room and gives them a breathing treatment and is there with them, as opposed to being at home where their spouse may be frightened. They call 911. It may take them 3 minutes to get there, which is pretty darn good. But 3 minutes of feeling like you can't breathe is an eternity. So we have had patients who decide they'd rather be in the hospital because they feel safer from a breathing aspect. It's normally usually that, or if it's a patient that has the potential for having a lot of bleeding, we might also have them stay in the hospital if they feel comfortable with that. Some people want to be at home, and we are as honest and upfront with them and helpful as we possibly can be. It's difficult in this day and age with socialized medicine to have round-the-clock treatment and care for people in their home. It's something those of us that are my age have all had to make our peace with, because you used to be able to have someone. I mean, when I was in nursing school, I made money, doing the overnight shift with older people that just wanted someone sitting there while they were sleeping. It's not that way anymore, unfortunately. Sometimes family circumstances can make things difficult. If someone is needing to work and can't take time off or owns their own business, and if there are children in the house that are too young to understand some of this, and you worry about what they think, and just the general unknown when it comes to someone passing away, these are sometimes the triggers for people saying, I wonder if we don't want to have a room at a hospice or go to the hospital. The biggest thing is you are not alone, like, at all. This is a big part of healthcare. It's a big part of life, and we have people that are good at discussing things with you. If you don't get anywhere with your doctor, there are lots of hotlines that you can phone, especially if you phone the hospital. You can phone the palliative care clinic, and you can ask your family to sort of set the tone and the pace of care, just so that you can take time to be a family together. That's the one thing that we really do want to have, is have someone not run off their feet, although it is a thing you want to do, which is, a part of loving your family member is wanting to take care of them forever. It's impossible to do when you have other responsibilities that you have to make work. So it can be difficult, and there is help there, a lot of help. Next slide. So anything considering, OHIP pays for medical expenses. The real problem, as I said, it can be staffing, particularly at home. After COVID, healthcare services have been really stretched, and it is unlikely, as I said, that anyone can find around the clock care at home. My advice, it's difficult. My advice, I think if I were in the shoes I was before, I would love to have someone that could be there in the evening or the nighttime, because then I felt as if I was better equipped to do things in the daytime. Large families with extended members and lots of friends have a lot more people to help you. So don't be afraid to reach out. I know I've helped many other families, and I've got many friends with extended families, and many a time I've gone over when someone's just come home from the hospital and a baby is getting christened or something like that. And I've said, you guys go, I'll stay home with them and not worry about it. And this is if you feel that it's too much of a stretch, or it's the kind of thing that's really taking 6 months or something like that, and you thought you could do it, and you start to feel as if you can't, this is the time to think about palliative care or hospice. And as I said, we're here for you. So it's not anything that's separate. It's the OHIP covers all of the expenses. It's just that when it comes to that one-on-one care at home, it can be difficult to set up. We'd like to think it isn't, but it is. Next slide. So to consider if you're staying at home, there is one thing that I actually did, employment insurance. So if you've got a job that you're paying, or your employer is paying for employment insurance, if you are laid off or your hours are reduced, they will pay what's called caregiver benefits. It's up to a maximum of 55% of your pay, and it's up to a maximum of $638 a week, and up to a maximum of 6 months. This has been beefed up, I think, from 10 years ago, because I got $400 a week for a maximum of 4 weeks, as long as my parents weren't in the same year. So they have become much, I think what they're realizing is, people want their family taking care of them, and families want to help, but they just can't take all that time off work in this day and age. Everybody's, got work, and they can't just say, I'm quitting my job to do this, because you can't be guaranteed of a great job when you come back. So you would need a note from the doctor that it's just regarding the fact that they're caring for a loved one who has a life-limiting illness. That's all it needs to say. It doesn't need to say anything specific. And you would need to have room at home for things like if they require oxygen tanks, or a hospital bed, or a rolling commode if they can get up to use the washroom, or any of those other things. So you would need, a lot of people choose to put a hospital bed in a living room so that they're sort of centrally located with the family. And the other thing to consider is if you're comfortable with healthcare people coming to your home. I have met people that are not comfortable with that at all, and there's not a lot that we can do to help them be comfortable. I think it's just if they've been a little bit of a loner all their life, they're not going to change now. So these are the people that we really do try to get them into a room off to the side in a hospital room with nurses that know that they please knock on the door, they respect their privacy, and they didn't want people coming to their home. Next slide. So there is support through all of the aspects of this. There's a number of social workers and spiritual care workers, as I said, of all faiths, in both the hospital and community settings. So again, if you have already some home care, the care coordinator can get social work and spiritual care and palliative care involved. There's a lot on the internet. There's something called Canadian Virtual Hospice. They assist with any stage. If you have just had bad news, they have people that can talk you through things and help you out if you just don't even know where to turn. there's another site called the Palliative Caregiver. This is supported by WebMD. So they do provide a lot of information, and their WebMD's goal in life is to provide information and definitions of things to people who don't understand the medical system. So it is a talent. There are doctors that will tell you something and it's just over your head, mumbo jumbo Latin. And then there are doctors that can break it down so that they'll draw you a picture and they'll explain it easily and you understand what's coming. And what we want is to have those for people. So that's another good website to help understand what's going on. And you can do that anonymously, privately at home with your cup of tea. It's kind of a nice thing. Next slide. So now we can get to the part there. If all of this is too much for someone, Canada, as in some other European countries, South America, Colombia, and now Australia and New Zealand in some territories, they have a process which is called medical assistance in dying. The acronym for that is MAID, M-A-I-D. And basically what it is there was a law passed in 2015, which they took a year to get the medical system ready for this. And what it allows is if a person meets criteria in the law, so it's written down in a law, there are 8 things that they have to meet, bar none. I can ask the person these questions, and they have to sign a request form. So what it does is it makes it so that a doctor or a nurse practitioner can administer medications to a patient with the goal of ending that patient's life. The patient is the only person that can ask for this. You cannot ask for this for someone else. You cannot ask for this if you have dementia. You can't ask for it in your will. It has to be a person who meets the criteria in the legislation, which is being over 18, having an OHIP card, making this decision voluntarily, having what they call grievous irremediable illness. So it's not just for someone that walks in and says, I don't feel great, that's it. You have to jump through some hoops for this. You have to be assessed by 2 physicians and or a nurse practitioner. And it make a lot of decisions along the way. It's a really big decision for people. But I have to say in Canada, it's been looked at since 1996. The Supreme Court ruled 5-4 against a person who took them to court. And for me, I look at that and I think in 1996, that was almost a tie in the Supreme Court, which tells me that Canadians were very accepting of this. They do this in the Netherlands, Belgium, Luxembourg, I think Switzerland as well. So in 2015, as I said, another case was brought forward, actually by the children of a woman who had chosen to go to Switzerland to end her life in a dignified way through having medications. And they felt that, you know what, she had to do that. This is not keeping with the Canadian Charter of Rights and Freedoms to have, like, basically the first woman said to challenge it in 1996, said, whose body is this? I can't make any decisions about ending my life. And she had an extremely bad neurodegenerative disease, and she just didn't feel like she had any life worth living. So it is mainly about quality of life, but it is also about irremediable diseases and things that are wrong with you, and that this may cause suffering and pain. It may cause suffering and pain for the family, all of those sorts of things. So it was a long time in coming. It is well thought out. The physicians, it is not a new law. It is a law that exempts doctors from being charged if they are asked by a patient and there's anything that does not follow the law. There has never been anyone charged in all of Canada in 6 years. So we are doing it by the book correctly. Every doctor talks to at least 3 or 4 other doctors for opinions. They call the Canadian Medical Protective Agency. Every case has to be called to the coroner afterward to make sure that everything was done exactly by the book. But basically what it is a patient comes to the doctor and asks, I would like to just go on my own terms with my family surrounding me and my favorite music. And that's often what happens. Is it can be quite a nice, some people end up actually enjoying planning this whole situation for themselves. So move forward to another slide. Oops, there we go. So as I said, MAID is the most common thing that we call it. And as I said, again, the patient is the only person that can ask for this. There is no chance that anyone is ever going to say to you in the hospital, this is what we're going to do. It is not a treatment option. It is something that you ask for because you feel that the burden of your symptoms is just too much. Some people say they don't want to be a burden on their family. That used to be something that we weren't comfortable with. We then realized, I started writing down their ages. It's a lot of people in the 80-year-old bracket. These are the people that had no palliative care for their parents, who may have been in the process of dying in the living room while they're raising a family, maybe trying to have a job. They have vowed that they will not have their children have to take care of them in their old age. And when you talk to them about it, they are adamant about it. Like they do not want to go back home. Even if their daughters or sons say, but we'll take care of you. They're like, no, I don't want it to be like that. For some people, it's all about having their own choice to go when they want. Some people are very afraid to be in a nursing home, afraid of losing all their dignity because they're losing all of their medical things that they can't perform for themselves anymore, all of their daily living things, not being able to dress or bathe themselves or anything like that. So it's a different quality of life indicator for everybody, but with a good conversation with people, you can generally get out of them what it is that they're worried about and afraid of. A lot of people, it's pain. We can go to the next slide. I think I included some statistics. I didn't. So roughly about 65% of our patients have cancer, because I think that's the biggest group of people who wished that there was a better way than just wasting away to nothing and having an incredible amount of pain depending on your cancer. So how would this happen? Anyone who asks about MAID by law must be given a timely referral to either a doctor or nurse practitioner who can assess them for it, or to me in the hospital, or to someone that can pass that along. This has been challenged in the courts by a few agencies that feel that no one should have to participate in this. And I have to say, within the walls of the hospital, within the walls of any hospital or in the community, no one has to participate in any degree of caring for a patient that's asking about this if they're not comfortable. I want everyone, as we all do, to be comfortable in the workplace. And this is a big issue, morally, ethically, religiously, spiritually, just a huge issue. So we make sure that everyone is comfortable with it. But by law, the federal government has decided that no matter what your position in a hospital, your religious conviction does not outweigh the patient's right, which has been established by law in the Charter of Rights and Freedoms. So if it means just giving it to your friend, then just do that as long as we get it. And generally people are pretty good about that. We have had discussions with some people that we know are less than thrilled with this idea, but I think the longer it's here and the more they recognize the people that are involved with it, the more I think they're seeing that this is very patient driven. It's one of the most patient driven things in the hospital. The eligibility criteria, as I said, is in the law. So it, as well as being a part of a professional's opinion. So they do have to review everything with a coroner afterward. And so a lot of consideration goes into it. It's taken quite seriously. Next slide. So the only other thing I think that I would say about this is, as surprising as the medical assistance in dying can be for some people, it really is a very peaceful way to go. I've spent the majority of my time working in intensive care. People plan this day for ages. They plan their music, they plan who's going to be there. We've had some, I hesitate to say it, we have had some really lovely, lovely days where people have died and they have spent a really nice day with their family. So I think it's not accepted by all cultures or religions, nor do we expect it to be. It's one of the things that if you've moved to Canada, this is an option. It's not going to be something that anybody is like, I don't want anyone to think if they come to the hospital and they're on the palliative care unit, that somebody's going to bring this up and they're all of a sudden they're going down that road. There's so many safeguards in place, so many. If I ever had an inkling that someone was not comfortable with it or was a little waffly about it, I literally just say to them, you don't seem very committed to this decision. And if they're not, they're not. I might hear from them in 6 months. I might not. I might hear from someone in a year. It's open-ended and you can say, forget it at any time. So if you say May 31st is my day and everything's planned and the doctors arrive on May 31st, if you say, you know what, I don't want to do this, we walk away because it's your life. And you think that you're 100% sure of what you want to do and you change your mind at the last minute, that's fine. We're not thrilled with people that change their mind and then call next week. We would like you to sort of give it a little more thought, but we will obviously come back to someone who says, you know what, I've thought about it for a few weeks and I didn't think I was ready, but I am. So it's completely the most completely driven by patients thing you will find in healthcare. So nothing is ever going to happen to anyone without their permission. So to get more information on the internet, because this is such a, it's something that it's nice to be able to be anonymous. There's a site called bridgec14.org. And I have to be honest, I'm on the board of advisors for them. They offer a ton of information for families, family members, healthcare providers, lots and lots of podcasts, lots of interviews with people, lots of resources. They have grieving groups for afterwards, and it can either be anonymous or it can be one-on-one with someone that you talk to over the phone. There's just a ton of resources there. And as I said, it can be completely anonymous. You don't have to be face-to-face with other people at all. The whole process can be completely anonymous. We have a number of people who have said they don't want certain people to know that this is what's happened, and that's the way it is. It's the patient and their family's decision who knows this. There's nothing on any of the paperwork that goes to the coroner or to a funeral home or anywhere that says this is what's happened. It will say lung cancer. It will not say anything about this. And then, so there is a hotline if anyone does want any information, and that's at the bottom, the 1866 number, and they would be able to give you much, much, much more information about medical assistance in dying as an option as well. So some people, I explain to them that it's as if you're on a tree and you're the squirrel and you're on the palliative care tree. And sometimes you feel like this is just not for me. It's taking a long time and I just want to go. Some people really literally, that's how they voice it. They say, I just want to go. And what I tell them is, just because you're on this branch doesn't mean you can't jump over to this branch. So you can jump back. You're never locked into something because it's a big deal. I think
Palliative.
Does anybody have any questions or anything?
Thank you very much, Sue, for this very informative presentation. And if anybody has any question, comment, please feel free to unmute yourself and ask your question ahead.
Oh, I do see a hand. Or is that me? Oh, that's me.
So, well, actually, Sue, I do have a question. So, taking into consideration the legal aspect of the palliative care, who is supposed to give that final consent, final word? And if the patient was not, in a circumstance that could allow him to express his wish or will, so who's supposed to take that decision on behalf of him?
So for where we are now, they are working on making it part of advanced directives so that a patient could say, if I have this or this or this disease, or I can't take care of myself, I would like to have a medical assisted death. What we have right now, we've moved from 2 years ago, the person would have to have their mental capacity the day that they were going to die. What was happening is that people were refusing to take medications because they didn't want to be groggy, because they're very committed to this process of being awake with their family talking to them as they pass away. So that got changed with the last round of legislative changes. And what we do now is the doctors, some of the doctors, there are palliative care doctors that do a lot of them do MAID assessments, and a lot of them are the doctors that give the medications. There are a lot of doctors that are not palliative care doctors that believe in this and do. There are a fair number of family doctors in London. There's intensive care doctors in London. There are internal medicine doctors in London that see patients for this. So there's quite a few options as far as what kind of doctor it is. The person who would do the final "you're eligible" is, it has to be both of the people who have seen them. They have to agree. If one doesn't agree, you have every right to ask for another opinion, as with anything in medicine. And if we can't find two people who can agree, we have to do the best we can with what we have for that person to say, no one's under the obligation to end someone's life if they're not comfortable with it, which includes the doctors performing it. So it is something that is out there and offered, and you have a right to ask for. The flip side of it is no physician has to be forced into doing this ever at all. It's very opt-in. It can be emotionally draining after a while, or there are some doctors for whom this is the thing that they really like doing, is helping people exit the world in the way that they've chosen. So what we do now is the doctor who is going to give the medications and the patient sign what's called a waiver of final consent. And that means that the family would probably call on a Tuesday and say, oh boy, they're really not very much with the program. Like, they didn't know my name and they couldn't remember what day of the week it was. They forgot that the hockey game was on tonight. And the doctor can come and see them and they can talk about it and say, well, do you want to see if they're better tomorrow? Or what would you like to do? And at that point, because they've signed that, when they have their mental capacity, the doctor is comfortable going ahead with it because it's their express wish. However, what we've come up with is a few bad situations where somebody comes to the emergency department, they've lost mental capacity, they've signed a waiver with Dr. Smith, only Dr. Smith. It can't be transferred to another doctor. Now we have to start fresh. Now they've lost their mental capacity. that they can't even take part in a new assessment because capacity is part of the assessment process. So what we've started doing is having two, if we really think there might be a problem, we're having two doctors sign the waiver. And that way, at least there's got to be somebody that's either in town or has hospital privileges, because sometimes people don't have hospital privileges. And toward the end, someone gets anxious and calls 911, and they do end up in the hospital, but their doctor doesn't have privileges, and we can't unfortunately help them out because they've signed that waiver before. And the other thing that is, I sort of brought up early on, and they've written into it, is if the person is showing any signs of being fearful, not trusting what's going on, refusing, or pushing the doctor away, we don't go ahead, because that's traumatic for the patient, traumatic for the family, traumatic for the doctor. The only way that we ever get around that is if the patient and doctor have a agreement, another agreement, that they could have a couple of milligrams of something sedating before they get the other medications. If they're willing to do that, then we can go ahead. But even at that time, if you're sitting beside someone and you say that I'm just going to give you a wee little bit of a needle that'll calm you down, there are patients that will completely set them off, and they'll, be trying to fight with you. And that's when we have to walk away. There is something called palliative sedation, specifically for patients that have agitation toward the end of life, which is quite common. And so it just sort of steps up the amount of medications. So the person is a little more sedated than they would normally be with palliative care, but they're also not aware of a lot of the symptoms of actually the physical dying. They're not aware of anything like feeling anxious or trying to crawl out of bed, all of those sorts of things that sometimes it can be part of the whole process. So there are safeguards so that, obviously nothing's going to happen to anyone who doesn't want it to happen. But now we've got that extra little thing that we can do so that we don't have people for not taking medications. And it also means that MAID isn't the goal. Initially people would really want to come into the hospital in the process of actively dying because they'd promised them that they would have MAID. And I have talked more than a couple of people out of that and said, you are going to be at home. I can get you the doctor there in 10 minutes. I just don't think they wanted to die in an ambulance. And what if the ambulance doesn't get there? Just hold their hand and stay with them and pat their head, see if the nurse is there and they can give them some medications. But we don't want MAID to be the goal for people. We want a comfortable, dignified death to be the goal. It's not able to be made all the time. Okay.
I see. Thank you very much. So is there any other question, comment, pursue here? Well, taking none here, I will conclude our session by thanking Sue Miller and London Health Science Center. Thank you all very much for participating on this session. I would be very grateful if you can fill out the feedback form in the chat, so that would tell us how the RRAI is doing. And thank you very much, everyone. Have a wonderful rest of the day, and we are looking forward to see you again at another session with Rise.